My name is Hung, and today I will present my poster about Fanconi syndrome-induced severe osteomyelitis myopathy. This is an uncommon side effect of tenofovir-disoproxil fumarate, and hypophosphatemic osteomalacia stands out as a rare yet reversible contributor to muscle weakness, particularly among adults. Fanconi syndrome, although infrequent, can indeed lead to hypophosphatemic osteomalacia and may be linked to uncommon side effects of tenofovir-disoproxil fumarate, and we present a case of progressive myopathy secondary to hypophosphatemic osteomalacia induced by Fanconi syndrome. Due to prolonged usage of tenofovir-disoproxil fumarate, the condition was initially misdiagnosed as drug-induced mitochondrial myopathy. A 42-year-old man was admitted to the hospital due to gradual hip pain and tetraplegia. He had previously been diagnosed with chronic hepatitis B and undergoing treatment with tenofovir-disoproxil fumarate for the past decade. A year before admission, he began experiencing dull pain in both thighs and was diagnosed with bilateral hip arthritis. Despite using NSAID, his walking worsened, leaving him wheelchair-bound. His wife noticed that he had a significant reduction in height from 157 cm to 149 cm within 1 year. Upon examination, the patient displayed tetraplegia, primarily affecting the proximal limbs. Deep tendon reflexes were normal without any sensory deficits, suggesting myopathy. Additionally, he experienced diffuse tender bone pain, notably in the pelvic and femoral regions. Creatine kinase and thyroid function was normal. Nerve conduction study were normal, and there were no myogenic pattern on electromyography. Suspecting drug-induced mitochondrial myopathy due to extended TDF usage, a muscle biopsy were performed, but there were no specific change identified. On routine blood tests, several abnormalities were noted: hypokalemia, hypocalcemia, and metabolic acidosis, evident from arterial blood gas analysis. Additionally, macroproteinuria and glycoluria were detected on urinalysis. These findings collectively pointed toward a diagnosis of Fanconi syndrome. Further blood tests revealed elevated alkaline phosphatase level, hypophosphatemia, low vitamin D, and normal parathyroid hormone concentration. Bone densitometry demonstrated low T-score at the spine and femoral neck. Subsequently, the patient was diagnosed with hypophosphatemic osteomalacia attributed to the Fanconi syndrome after excluding other potential causes. Ultimately, his muscle weakness was linked to hypophosphatemic osteomalacia, a consequence of Fanconi syndrome resulting from prolonged TDF uses. Following correction the electrolyte imbalance, renal tubular acidosis, and transitioning to non-tenofovir-based hepatitis medication regimen, resolution of both Fanconi syndrome and his weakness were achieved within 6 months. And this report emphasized the significance of recognizing hypophosphatemic osteomalacia as a rare but reversible complication of prolonged TDF exposure, which can lead to a severe muscle weakness. In our case, a delay of 10 years is observed between TDF treatment and the onset of the muscle weakness. Simple screening tests such as ionogram and urine dipstick tests can enable early diagnosis of this condition, ensuring timely management and recovery. The rapid identification of myopathy etiology also helps prevent unnecessary and costly diagnostic intervention.